Policing Patients, the Hidden Costs of Surveillance in Health, featuring Dr. Elizabe Chiarello. In this episode, we dive into the complexities of the opioid crisis with Dr. Elizabe Chiarello, Associate Professor of Sociology and author of Policing Patients, Treatment and Surveillance on the Frontlines of the Opioid Crisis. Drawing from hundreds of interviews with physicians, pharmacists, and law enforcement agents, Dr. Chiarello explores how prescription drug monitoring programs, PDMPs, are reshaping the boundaries between healthcare and criminal justice. We discuss the challenges faced by medical providers navigating between treatment and surveillance, the unintended consequences of PDMPs, and how these tools are both a resource and a Trojan horse for patient care. Dr. Chiarello offers critical insights on harm reduction, balancing care with safety, and the policies needed to improve outcomes for those impacted by opioid use disorder. Our guest on this episode is Dr. Elizabe Chiarello, who is an associate professor of sociology at St. Louis University, a former fellow at the Harvard-Radcliffe Institute, and a frequent public commentator on opioid-related topics. Her work has been featured in the New York Times, the USA Today, and on Bloomberg News, among other leading media outlets. In Policing Patients, Chiarello draws on hundreds of in-depth interviews with physicians, pharmacists, and enforcement agents across the United States to take readers to the front lines of the opioid crisis, where medical providers must make difficult choices between treating and punishing the people in their care. States now employ prescription drug monitoring programs capable of tracking all controlled substances within a state and across state lines. Chiarello describes how the reliance on these databases blur the lines between medicine and criminal justice and pits pain sufferers against people with substance use disorders in a zero-sum game. Shedding critical insight on this brave new world of healthcare, Policing Patients urges medical providers to reaffirm their roles as healers and proposes invaluable policy solutions centered on treatment, prevention, and harm reduction. To learn more about our guest, you can visit her at our website at www.lizchiarello.com. You can also find her on Twitter and Blue Sky.
This is Talking Addiction and Recovery, the podcast talking, you guessed it, all about addiction and recovery. Join your host, licensed professional counselor Andrew J. Schreier, as he and his guests break down recovery topics with raw honesty, delving into niche conversations around the topics of substance abuse, mental health, and gambling. We intend to meet individuals where they are on their own personal journey of recovery, with dignity, respect, and compassion. We'll do more than talk addiction and recovery. We'll explore it. We're glad you've joined us. Here with today's episode, your host, Andrew Schreier.
Welcome, Liz, to Talking Addiction and Recovery podcast. It's really great to have you on.
Thank you. It's great to be here.
You are the author of Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis, and we're going to talk a lot about that. But before we do, can you just give audience members a little bit of background?
About the book or about
About
me?
you.
Sure. So I am a medical sociologist and a socio-legal scholar. So I do work at the intersection of healthcare and law. I've spent the last 15 years studying the overdose crisis, and Policing Patients is my first book.
That's amazing. And yeah, let's get right into the book because I was excited to hear about it because I've been familiar with PDMP, and then after I read your book, I got so much more knowledge about it. So for people who don't even know what that is, can you talk about it and get them a little bit more familiar with what we reference by PDMP?
Absolutely. So PDMPs are prescription drug monitoring programs. They are statewide databases that track controlled substances in a state. So controlled substances, of course, are scheduled by the DEA, and they include a wide variety of drugs, not just opioids. And so states, largely in like 2005 to 2015 or so, the majority of prescription drug monitoring programs were adopted at the state level, and they track pharmacy dispensing data. So you have a prescription for oxycodone, and you go to your pharmacy, you give them the prescription, they give you the medication. They then send that prescription to whatever organization holds the prescription drug monitoring program. So sometimes it's the Department of Justice, sometimes it's the Board of Health or the Board of Pharmacy. And then they share that information through a public-private partnership with an organization called Bamboo Health. in most states. And Bamboo compiles all of that information about your opioid and everybody else's controlled substances, and then feeds that information back to healthcare providers, physicians, and pharmacists who can use it to monitor patients. But they also feed the same information to law enforcement who can use it to monitor providers and patients. So PDMPs are two-tiered surveillance technologies that track healthcare providers and patients at the individual level around controlled substances.
And the amazing part of your book is you interview quite a bit of people from different roles, and I want to dive into that. But one of my first questions about it is there's a lot that's been written about opioids, overdose. I've got a ton of books, there's articles, there's research out there. This is one that never really gained a lot of attention as far as the topics related to it. So I'm curious, like, what drew you to this interest in writing a whole book about the PDMP?
So I was thinking back to why I turned to the PDMP to begin with, and I think it was a confluence of a couple of different factors. So I remember that I had heard a little bit about them when I was interviewing pharmacists for the first wave of this study. Every now and again, somebody would say something about this electronic database or the prescription drug monitoring program, and they weren't really in routine use. Nobody really knew what they were, except for a handful of pharmacists. And so I got interested in understanding what these technologies were. And I remember I sat down with a friend of mine who does work on law enforcement. She studies guns. And she was like, "What is this technology?" And she said, "Let's look up the company that has this technology." And so we looked them up, and she said, "It's so interesting to look at their other offerings because they have this ostensibly healthcare technology, but they also make all of this technology for law enforcement." And so that really got me thinking, because there was a lot of sociology developing at the time that was talking about how technology affected work and how technology affected people's access to resources. So people were looking at technologies used in welfare offices, technologies used to allocate housing for people who are unhoused, um, technology used by law enforcement. And so I was interested in this technology, because it's a technology that's shared across two fields. It's used by healthcare and it's used by law enforcement. And so I wanted to understand how workers in these two different fields were using the same technology, ostensibly to different ends. And so it made it a really interesting case for understanding how technology operates in different kinds of social contexts.
So from what you originally knew about it to then diving into the research, the interviews, writing the book, your knowledge of it, I imagine, just grew exponentially from what you originally learned of the PDMP or initially learned about it.
Oh, I learned so much about it. And it was really interesting to think about it in the context of all of these other technologies and what sociologists and critical technology studies, people working in that area, were thinking about these technologies and how they operated. And so I kind of backed my way into studying technology in a way that I didn't originally anticipate. But then I learned a lot about how technology transforms work processes, interactions between healthcare providers and patients, interactions between healthcare providers and law enforcement. And so it was a really fascinating research trajectory.
Yeah, and you mentioned in the book uh, physicians, pharmacists, law enforcement, and investigators in those four roles. And I'm just curious, you know, how was your approach when you were trying to find people to talk about it? When you did you get people who were really wanting to share? What sort of initial, response did you get when you're trying to reach all these different people, their different roles? Because it was quite a bit of people. It wasn't one interview or two. This was hundreds, correct?
It was 337 interviews with physicians, pharmacists, and enforcement agents over a 10-year period. So, yes, it was an extraordinary number of interviews, and I did them all by myself. So, I learned a lot. I started with pharmacists, and pharmacists are really interesting. They're kind of the underdog of the healthcare world. When I told people that I was studying pharmacist discretion, people thought that I was joking, because nobody thinks about pharmacists as having discretion. A lot of people think that pharmacists just dispense whatever it is that the doctor writes, but that's not true. Pharmacists work under their own professional licenses, and they are the ultimate gatekeepers to medications. It's not the doctor who hands you the bag of pills, it's the pharmacist. And so most of their discretion is really around refusal. They're able to say no to providing a medication, particularly a medication that they think is going to harm you. But they can also say no for a variety of other reasons. And so understanding how pharmacists make decisions is really critical. So I started with pharmacists, and I think pharmacists were eager to talk to me for a couple of reasons. One is this, I started in 2009, so it was before the overdose crisis was really on the national radar. And I started by talking to them about ethical issues that they were facing. I was actually interested at the time in emergency contraception because it had gotten a lot of attention. But pharmacists really wanted to talk about opioids because it's what they were dealing with. They were kind of canaries in the coal mine. They were seeing this problem, but they didn't really know how to deal with it. And so I think they talked to me partly because they were dealing with a problem that they didn't really know how to handle, and then also because nobody talks to them.
Yeah, or
And
voice, like who gets their voice and where do they share theirs? So I can see how that was uh, them wanting to talk about it.
exactly. So they were really eager to talk to me at first, although I have to tell you, like, once all of those lawsuits started coming through and opioids were really on everybody's radar, pharmacists really then were not as eager to talk to me. As I moved deeper into the project, it was harder and harder to get in touch with pharmacists. But once I knew what was happening for the pharmacists, I then got curious. I was like, okay, well, so pharmacists are grappling with this, but so are physicians, and so is law enforcement. And so then I started reaching out to people in those groups. And with law enforcement, well, actually with pharmacists, they were pretty easy. You call them, you ask them if they're willing to talk to you. Usually they are. And then they were pretty easy to meet up with. Law enforcement, it was more networking. I knew a few people and then they connected me to other people who connected me to other people. And that's really how I made my way through law enforcement. Physicians were really, really hard, because it's just hard to even get to a physician to ask them. And especially in Florida, I have a story in the book where, like, I was trying to recruit all of these physicians and nobody would get back to me and nobody wanted to talk to me. And I randomly ran into the physician I wanted to talk to in the elevator of her building. And so I tried to recruit her there and she said yes, and I got to do that interview. But physicians were especially hard. I think partly because they're so busy and because there's so many barriers to accessing them, but also because they've been blamed for the opioid crisis. And so I think that they were less inclined to have those conversations than some of these other professionals.
What were some of your big takeaways as you interviewed, different roles who had different responsibilities and they come from the two like the two level two tier of like surveillance and medical care, like what were some of the things that really stood out to you as far as after doing all these interviews that really stood out to you and what you were talking about in your book?
A good question. I mean, I think you'll appreciate this as someone who's in counseling. My sense was really everybody was doing the best they can in the circumstances that they're in, but they were all in pretty challenging circumstances. And certainly the narratives that were being told about the opioid crisis were affecting how they were thinking about their own work. So for law enforcement, a lot of them were just starting to look at doctors as drug dealers. So they were developing whole new tactics for investigating physicians, identifying problematic physicians, and ultimately going after them. And then healthcare providers were in this really transformative moment where they were really being pulled in two different directions. On the one hand, they were trying to do the best that they could do for their patients. And on the other hand, they were being asked to police their patients and to actually handle this really massive social problem that we're dealing with, and that they had been blamed for. And so everybody was in kind of a difficult situation. And so, in terms of takeaways, I was really interested in seeing the way that the prescription drug monitoring program in particular helped law enforcement encroach more deeply into healthcare territory. It gave them access to information that they didn't previously have. But it helped healthcare providers transform into kind of a hybrid caregiving, policing type of profession. And so watching healthcare providers straddle that line was really eye-opening for me because it's not how we normally think about healthcare providers. We normally think that they're committed to medical ethics, that they're really concerned about doing no harm, that their patients are their first priority. And so watching them get into a position where they had these divided loyalties was really eye-opening. And I wanted to understand the mechanisms by which that was happening.
And I think your book did a good job of sort of showing that it wasn't like this role versus this role versus this role, but even like some people you know, in like pharmacists or physicians viewing the PDMP as, effective in a treatment tool. Some view it like there's some controversy even between people in same roles as to its use, its effectiveness, and is it this, is it not? How did you find that balance of even when you were working with, they're talking with someone in the same role as someone else, that there wasn't necessarily we all agree on this?
Yeah, I mean, it was really eye-opening because one of the questions that I asked them was, especially with the healthcare providers, I said to them, okay, you have the prescription drug monitoring program, and you could imagine that this operates as a healthcare tool. It's giving you information about your patient that you otherwise don't have. But some people might say that it looks like an enforcement tool, and not just the PDMP. When I'm talking, pharmacists largely have the PDMP. But when you talk to doctors, doctors are doing all kinds of things in terms of managing pain patients. So they are having them sign a pain contract, which is a legalistic document that sets parameters around their care. They're doing urine drug screens. So they're checking to make sure that the drug they've prescribed is in the patient's system, but also make sure that other drugs are not in the patient's system. They're checking them in the prescription drug monitoring program. And then some doctors are doing random pill counts where they're saying, show up at my office within 24 hours or 48 hours. I'm going to count the number of pills that are in your bottle. And I just want you to picture for a minute us doing that with any other kind of medication. So you're on a blood thinner, or you're on insulin, and your doctor is going to count, how much of your medication is remaining before they decide whether to prescribe that to you again. We just don't generally do that in medicine. That's something that we normally think about parole officers or probation officers doing. And so I asked them that. I said, you're using all of these tools in your work, but some people would say that these look like enforcement tools. How do you make sense of that? And some of them said, yeah, I can see why this is an enforcement tool, but it's the best we have. And others said, no, it's not an enforcement tool. It's really helping me do better medicine. Um, and the reason that in the book I challenge that idea is because turning a patient away, firing a patient, or refusing to provide them with care is not better medicine. I mean, it's really hard to make that argument that it's better medicine. It certainly protects healthcare providers from enforcement consequences, but does it help patients? I mean, you and I both know that addiction doesn't go away just because the patient walks out the door. And so, where are those patients going? Are they turning to the illegal drug supply, which is toxic and incredibly dangerous at this moment? If that's what's happening, then our physicians and our pharmacists are not doing their jobs as healthcare providers when they just turn a patient away with no other alternative.
Yeah, there was a when I was reading your book, I'm a big person on language. Like I've been doing a lot of stigmatizing language and language matters. And part of me, I was thinking, and I'm curious to know your thoughts on this, was there's language about like surveillance, monitoring, policing, investigating. We look at a difficult situation versus sometimes people refer to someone as a difficult patient. And I was trying to juggle all those in my mind because sometimes I know like when you go get care, sometimes they say, hey, we want to monitor you, and they might have something attached to you or they might be doing something. But though a lot of those words came up a lot in the book, and to me, I'm like, how does that fit with like whoever's using it? Is someone using this that it would be like, well, this is more surveillance. This person's using this, and it falls under like more of like monitoring versus investigating. So I I grapple with that a lot when I was reading it because those are just terms that when you read those they're pretty strong and they can resonate with certain things of what people are doing or their intent of what they're doing. So I'm curious your thoughts on that sort of language that's used in this technology and topic.
Yeah, I think we have to think a lot about intent and we have to think a lot about outcome. Um, And so you're right, monitoring is something that gets used a lot in healthcare. They're going to monitor your heart rate. They're going to monitor your blood pressure. They're going to monitor, all sorts of things. And so monitoring is normal in healthcare spaces. Surveillance is a bit of a different thing. I mean, that's certainly a spin or investigating a patient. That's different language. And so it depends on what you're using it for. And certainly, there are physicians that I've talked to who have said, I use the prescription drug monitoring program, but I use it as a healthcare tool. And they're able to explain how they use it as a healthcare tool. But if you're using it as a lie detector, if you're using it, you're saying, okay, I'm prescribing this medication to you, but I don't trust that you're not going to other doctors, and I don't trust that you're not going to other pharmacies, and I don't trust that you're taking the medication that I've told you to take. And so now I'm going to surveil you to make sure that you're doing all of those things. And if you're not doing them, then I'm going to dismiss you as a patient. That's a very different set of intents and outcomes than saying, look, I'm going to monitor your blood pressure. And then if your blood pressure is high and I'm concerned about it, I'm going to take a different route. I'm going to continue to partner with you as a patient and make sure that we find the best possible outcome for you. And so my concern about surveillance and investigation and punishment is that it creates an adversarial relationship between healthcare providers and their patients, which I don't think serves a medical purpose and I don't think is aligned with healthcare ethics. Whereas monitoring suggests more of a partnership. I'm going to monitor you to make sure that your health is as good as it can possibly be. And then I'm going to team with you to make sure that we find other good alternatives. And so it positions providers and patients in a very different relationship to one another.
And when you were talking with and doing interviews, did you find that it was some people felt what they were doing was monitoring when it really sounded more like surveilling or policing? Like the individuals seem to that line was a little bit more difficult to understand, or it was blurred with what was going on, or the pressures that have been happening, and everything that was going on. That someone may be thinking they're doing this, but in reality, they were falling in line more with something different.
It didn't come up around so much as parsing the language, like that there were some people who said monitoring and there were some people who said surveilling and that those were different people. The place it really was evident was in um, the longitudinal study of pharmacists. So I had talked to pharmacists in 2009, and then I talked to them, from like 2013 to 2019. And I re-interviewed some of the same pharmacists. And what really stood out was how they thought about their gatekeeping roles. So I've talked about pharmacists in other work as medical, legal, fiscal, and moral gatekeepers. And I talk about how they navigate those roles differently in different organizational settings. But the conflict that really comes up when it comes to the overdose crisis is around medical and legal gatekeeping. On the one hand, they're looking at patients, they're using science to help them make decisions about medical care. But on the other hand, they're also thinking about the law, their legal responsibilities, patients' potential criminality, and how they monitor that. And so those two roles are in tension. And when I talked to pharmacists in 2009, they really understood that those were two different roles and they understood the tension between them. And so they would say things to me like, I'm a healthcare provider, I'm not a cop. I'm a healthcare provider, I'm not a detective. I shouldn't be engaged in all of this policing. I'm here to take care of my patients. And so that was how they drew a pretty clear boundary. By the time I was interviewing them in 2019, those two roles had fused into a single role. And they said things like, I'm helping by surveilling, I'm helping by tracking. And that to me was really surprising because they were no longer seeing the differences, but instead they were doing what I call a reframe and embrace strategy. They were reframing enforcement and and embracing it as care. And so it's much harder to tease apart. And you probably saw that with the language. Like it's harder than to tease those two things apart when providers are seeing them as part of the same role.
And what part then, because there's a lot, because when I read the stuff, I feel like I learned a lot about pharmacists more than anything else from the book, and I can't see them any differently now when I go in and I realize like a lot of what they do is not known to people and their role in things. And like I think a lot about my care when it comes to my doctor, and if he prescribes me a med, that the pharmacist is there to help to get me my med, and that's kind of like a simple way of like just helping to facilitate that access to care, so I also don't have to go back to my doctor to get it. So I think it was interesting to also read about how some of these interactions with one another in these roles were difficult. So like when a pharmacist, you know, calling a provider or a provider speaking to a pharmacist or like pharmacists dealing with law enforcement or investigators, like it was a lot of different people, moving around and all this going on that it you could sense, I guess part of like the pressure or the what all these roles were dealing with was just really challenging to many of them.
Yeah, absolutely. I mean, they were really struggling. And it's interesting to think about the hierarchy in which healthcare providers are situated. So there's a great book. It's an older sociology book. It's called The Social Transformation of American Medicine by Paul Starr. And he talks about how allopathic medicine, so the physicians we think about today, how they rose to power and what they did to subordinate all kinds of other professions like nurses, midwives, chiropractors, pharmacists, um, and osteopathic physicians. And so they rose to power, and then they've managed to stay on top of the medical hierarchy for decades now. And so pharmacists are subordinated to physicians in today's medical practice, but that's just a formal. If you think about kind of the formal relationships between those two professions, pharmacists are really subordinated, but pharmacists still have power. And they have power over patients, they have power over doctors, they have power in relation to other pharmacists. And then their relationship with law enforcement also changed quite a bit, and the PDMP plays a major role in that. So what happens with the physicians is pharmacists were using PDMPs far more regularly than physicians were, certainly at first, because a lot of the big pharmacy chains required pharmacists to use the technology. And so pharmacists had access to information that physicians didn't. And so in the past, they would call physicians and they would say, "Hey, I'm not so sure about, what you're prescribing for this patient." And doctors would get really mad and they would say, "Well, I'm the doctor and you are the pharmacist, so you do what I say." And then once they had information from the PDMP, it was like they had a tool for pushing back on this hierarchy. And they could say to the physician, well, did you know that your patient is going to 8 different doctors and that they're going, that they've been getting opioids from all of them? And the doctor didn't know that. And so that positions the pharmacist really differently. It gives them more information and it upsets that kind of information asymmetry that they had before. And then when it comes to law enforcement, um, pharmacists and law enforcement act in concert much more than physicians and law enforcement do. I talked to pharmacists who helped law enforcement catch their patients. They set up essentially a sting operation for law enforcement to come in and go after those patients. And so that was really interesting to hear about that from the side of pharmacists. But then I also heard it from law enforcement who said pharmacists are some of our best informants. They call us and they tell us about patients who might be engaged in illegal behavior, but they also tell us about physicians who might be engaged in illegal behavior. And so watching those relationships shift was really interesting to me and troubling because it's not really what we think about healthcare providers doing.
One of the questions I wanted to talk about, look at questions or things was you refer to the PDP as a Trojan horse, and you know, in essence, now it's been given, and I also think too about as I like think about like younger professionals coming into the work, me as a counselor, I think about what I came into the profession with, and then what a counselor today comes into learning that part of the PDMP will be a lot of what newer, younger, professionals will like that's just become normal to use with other things. Like it won't be such a difference to them. So can you sort of explain, when you talk about it as a Trojan horse, and then the second part with that is, now that it's been given and it's become pretty standardized in a lot of care, where do we go from there with this?
Yeah, these are great questions. So, with the Trojan horse, we have to go back to high school English and we have to think back to the Trojan horse story. And there's a critical detail that I think many people don't necessarily think about when they think about that story, but it's that the Trojans were horse people. Like it was kind of their thing. And so, when they saw this wooden horse, they thought to themselves, what better symbol to commemorate our victory over the Greeks than this fantastic horse? So when they wheeled it behind their gates, they didn't anticipate that hiding inside were Greeks who planned to kill them. And kill them they did and brought an end to the Trojan civilization. Um, the PDMP works in a similar way in that it smuggles in enforcement logics that come from law enforcement into healthcare spaces. And so and the reason that the PDMP is appealing is because we're in the middle of this huge social problem, the overdose crisis. We've been losing over 100,000 people a year. We've lost over 1 million of our loved ones. So we have this huge intractable social problem that nobody seems to be able to get a handle on. And then law enforcement offered healthcare a gift. And and I mean that quite literally. The PDMPs were developed through these Harold Rogers grants that come out of the Department of Justice. And so they gave states money to either establish a prescription drug monitoring program, to run the prescription drug monitoring program, or to enhance the prescription drug monitoring program. And so they gave the states money, they gave them this technology, and much like the Trojans who saw themselves in this enormous wooden horse, healthcare providers deal with a lot of technologies, especially the electronic health record. And frankly, the prescription drug monitoring program doesn't look that different from the electronic health record. But what they didn't anticipate was that this technology really works differently. It's a more pernicious technology than the electronic health record because it was designed for law enforcement and it's being used in healthcare. And it lacks all of those privacy protections that were normally afforded with our healthcare data. So PDMPs aren't protected under HIPAA. And so law enforcement can get access to individually identifiable healthcare data in a way that they couldn't through the electronic healthcare record. And so then that, I think, gets to your second question about where do we go from here? So PDMPs probably are not going away. And the problem with a technology is once it's created, people start to see all kinds of different uses for the technology and for the data that's created through the technology. Shoshana Zuboff talks about this when she talks about other technologies like, like the Nest thermostat or, our phone. She talks about the surveillance dividend. It's not enough to just sell a technology. You also have to surveil the people who are using it because our data are so valuable now. And so PDMPs probably are not going away, but there are probably ways for us to reorient them so that they do actually operate like a healthcare tool. And the most effective way to do that would be to incorporate them into the electronic health record, not as a separate system that then becomes incorporated, because then we still lose all of those privacy protections, but to actually include this data into the electronic health record and to give pharmacists access to the electronic health record, because then we could still create pretty strong firewalls so that law enforcement didn't have as easy access to this information. They wouldn't like it, but I do think we need to think about what health data privacy means in the digital age, and the PDMP is a really good place to start with that.
Yeah, would that be my counselor magic wand question would be, to make that change with how it would work. When you think about like so many people use it, it's becoming such a part of healthcare and different parts of this. Like what would you want like the various people to really know about this? Like your takeaway or your big like this is what I would really hope by reading this they walk away with because you have such a diverse audience of people and I think there's even more people that may read it and think about it who may have no idea what it was to begin with or no clue. So I just think your range of audience could be so large, and yet for some of these people, they use this tool every day. They use this all the time. For some, they're not even being aware of it being used. So, knowing that, how would you look at for readers, what would you really want them to think about or take with them from reading Policing Patients and everything that you did with the research and the interviews and everything gathered? What would and if you had a couple, you can use a couple, doesn't have to be just one, but what would be some
Okay.
of those things you'd want people to be able to think about as they read it and going forward?
There are several things that I'd want people to think about. First, I would really want them to recognize that we've been fed a single story about the opioid crisis. We've heard this story again and again, right? Some really bad actors came in, they sold an addictive medication, they hooked a nation, and they caused a lot of harm. And it's not that that story is not true, but that that story is incomplete. We really have to put our more recent story about the opioid crisis in the context of at least 120 years of drug policy. And we have to think about this pendulum that has been swinging between the medicalization and the criminalization of opioids. And we need to think about how that plays out differently depending on the population that we're talking about. We need to think about things like race, class, and gender and how they inform which drugs we criminalize and which drugs we medicalize, and who gets access to what kinds of medications, and who is punished most harshly for what kinds of illegal drugs. So I want people to take away the historical context and the myths about the opioid crisis. I want them to question those myths and have a more complete and comprehensive understanding of the problems that we're facing. I want people to come out of this with a really deep skepticism about technology. So there's another saying that actually has nothing to do with the Trojan horse, even though it does have to do with horses, which is never look a gift horse in the mouth. And that one actually comes from the fact that horses grow more teeth with age. And so you can tell how valuable a horse is by looking at their teeth. But you're basically like, looking to see how much a gift is worth before you accept it. I actually think we need to be careful about the gift of technology because boy, are we being given a lot of gifts right now. We're being given AI, and we're being given all kinds of technologies and databases and apps. And some of that technology is really helpful, and some of that technology is a thief in disguise. It looks like a gift, but what it's really doing is stealing our data or giving our data to somebody we wouldn't normally want to have access to our data. And so, especially in places like healthcare, where that information is so sensitive and so consequential, we really need to think about the role of technology, and we need to be far more cautious before incorporating those kinds of things into practice, where it's very hard to then get them back out. And then I think in terms of answers, letting bad actors do cruel things for 20 years and then trying to claw money back using an enormous lawsuit is just terrible public health policy. And so we need to be thinking more concretely in terms of harm reduction, treatment, and prevention. And by prevention, I mean capital P prevention, which is finding ways to make our communities as healthy as possible. So we're never going to stop drugs from coming into our communities. We're never going to stop people from using drugs. These abstinence-based models have not worked. So we need to engage in harm reduction, but we also need to find ways to prevent people from using drugs in ways that are chaotic. And I think the way we do that is through jobs and mental health treatment and stopping the cycle of trauma, and housing. I mean, there are all of these pieces that help people live a good life. And I don't think abstinence is necessarily the answer to living a good life, but I think having a robust system that helps meet our basic human needs and keep us in community with one another, that is how we get out of crises like this. We cannot arrest our way out of the opioid crisis any more than we've arrested our way out of any other crisis that we've had. We have to reconnect with our own humanity. And the way to do that is by providing people with the resources that they need to thrive.
I really appreciate the conversation today. Like I said, I was excited when the book came across and chance to read it and understand a lot of more of what's going on. I think I love the part about the narrative being incomplete and trying to gain a better understanding. I think also something about your book that I want to give praise for is giving the voices to many people. Because when you do these interviews and you give a voice to people that like pharmacists who may not have had a chance to, or even others who they feel like they may not be able to, but you've found a way to also give a lot of people a voice on such a important topic and a lot of issues within it. So I do think that also represents a lot more people on their role and their part in this story, and it's great to have that perspective given to readers. So yeah, I'm interested to hear more about it. I'll tell you, I've given it to people already. There's some people that I know who are in the field, and I've been interested to know what they think about it and their response to it. So it's gaining a lot of talk and discussion, and I think it's just going to bring a lot of value to what we're trying to do.
That's so nice to hear. Thank you.
Yeah, and audience members will have access to your website and where they can find the book and some of your accounts, and they can reach out and learn more. So I do want to thank you again for joining in and talking about policing patients. It was a good read, and I think a lot of value is coming out of it.
That all sounds great. Thank you so much for having me.
Thank you.
You've been listening to Talking Addiction and Recovery with Andrew J. Schreier. We're so glad you've joined us and invite you to connect further with the show and these topics at www.andrewjschreier.com. That's Andrew J. SCHREIER.com. You can also email us directly at talkingaddictionandrecovery@gmail.com and connect on social media, Instagram at Talking Addiction and Recovery, Facebook Talking Addiction and Recovery Podcast, and Twitter at TalkAR_podcast. To stay connected and never miss an episode, be sure to like, rate, and subscribe. Until next time, friends, let's keep talking addiction and recovery.